Hello everyone. Today I'm going to discuss about the one of the important topic in the surgery, so appendicitis. So in this topic, I'm going to discuss about the what is appendicitis, that is the introduction and anatomy of the appendicitis and also appendix, and what is the acute appendicitis, what are the causative factors, etiological factors, pathophysiology and clinical features, clinical diagnosis signs, and also how it will be in the appendix with the pregnancy, and about the medical management, how we are going to manage with the conservative management, the medicines, and also with IV fluids, and also surgical management, so which is also called as appendicectomy. So these are the learning objectives of this topic. So coming to the this appendix, so appendicitis is nothing but is any like a inflammation, anything happen to any organ, any tissues. So is ending with the itis. So is called is indicating the inflammations. So if any inflammation to the appendix, it is called as is appendicitis. So for example, if anything like a if for example, another example is if any inflammation to the liver, so it is called as hepatitis, or in case of the if any involvement of the like a tendon or tendinitis. So any tissue is going to be involved with the inflammations. So it is called as it is ends with the itis. So here I'm going to discuss about the this is the appendix is going to get the inflammations. So before going to explain about the appendicitis, so what is appendix actually? So appendix is a vegetation or is an organ. So it's nothing but so it is a useless body part in our body system. So it's also these are the remnant of the last functions that are our ancestors is a processed. So this is going to be so previously this function is there, but during the evaluations, the function of the appendix is going to be is less. So there is no the proper function in the current our body system. So because of this useless part may gives the complications, it may gives the swelling, so it may gives the complications such as severe like pain in the abdominal regions, and also it may chance to get the necrotic and also gangrene in the abdominal region. So it may give the severe complications. So it is a vermiform appendix. So it looks like is like a finger-like projections. So it's a most is a vegetatial organ. So it's a useless organs, and it is important surgery is only due to its tendency for the inflammations, resulting in the syndrome called as acute appendicitis. So it is a useless organ in the body, but it's a very important in the surgical procedures in the surgery. So because of it may chance to get the inflammations. So because of the inflammation of the appendix, so it may give the complication in the abdomen and also in the intestinal regions. So that is the importance in the surgical procedure in the surgery. And also is the acute appendicitis is the most common cause of the acute abdomen in the young adults. So because of the inflammation of the appendix, so this may give the severe pain in the umbilical regions, and also is going to be moves around to the either in the lower abdominal regions. So this is the causative factors. One of the causative factors were the acute abdomen, that means abdominal pain. So is only treatment method. So if it is stable conditions, we can manage with like a non-steroidal anti-inflammatory drugs, and also we can control with like a IV fluid with antibiotics drugs. So if it is not controllable, only treatment option is the appendicectomy. So that is the removal of this appendicitis, that is through the surgical procedures. So despite extraordinary advances in the modern radiographic imaging and also laboratory investigations, diagnosis of the appendicitis remains essentially clinical, requiring a mixture of the observations, surgical signs, and also clinical sense. So nowadays we got so many technologies. So we have got the imaging technology as well as the physical examination techniques, and also the physical assessment also we have to use. But we are not going to use the one criteria. So we have to take the investigation procedures and also physical examinations, as well as we have to check the any blood culture and also urine analysis. So all are going to be important to identify this inflammation of the appendix. So which is also called as appendicitis. So these all things are important to identifying the appendix. So if you see the anatomical positions of the appendix, so these are the location of the appendix is going to be, if you see here, so this is going to be is at the starting at the ascending colon. So this is a large intestine. So at the ascending colon, so where the is an attachment to the small intestine and large intestine. So is going to be the small projection like a finger-like projection at the ascending colon. So it's a location of the appendix. So these things are going to be, so is going to be alter the positions. So this depends upon the person to person is going to be vary. So this vermiform appendix is present only in mammals. So the position of the appendix is variable. So it's going to be different positions are going to be seen in the different type of the like persons. So in case of the retrocecal, so the retrocecal is going to be, if you see here, so this is the retrocecal positions. So it's going to be the above the towards the ascending colon. So it's going to be the some other type of the post-ileal, also pre-ileal, and pelvic regions and subcecal. So these are the different types of the appendicitis. So it depends upon the position of the these finger-like projections in the intestines. So highest percentage is when many people are going to get the retrocecal. So this is the position of the, so is towards the ascending colon. So the pelvic region is going to be the 21%, and also post-ileal is going to be the 5%. Paracecal will be the 2%. Subcecal is the 1.5%. Pre-ileal will be the 1%. So these are the different types of the the positions of the appendix. So the position of the base of the appendix is constant, but being found at the confluence of the three tenuous coli of the cecum, which fuse to form outer longitudinal muscles coat of the appendix. So, but the base, the everything is, if these are different positions are there, but if you see the base is going to be fixed at one place. So that is the anatomical positions of the appendix. Coming to the another anatomical structures regarding the mesoappendix, and also, so this mesoappendix is nothing but is going to be the mesentery is arising from the mesoappendix, so which is arising from the lower surface of the mesentery of the terminal ileums. So these are the terminal ileums, so which is also is the lower part of the small intestine. So this mesentery is originating from this terminal ileum. So it's going to attach to the appendix. So and also, so these are going to attach to the iliac appendicular artery. So it's a branch of lower division of ileocolic artery. So it lies in the pre-border of the mesoappendix. So it's going to the pre-border to the mesoappendix. So if anything damage, or if anything damage to this artery, is especially is the appendicular artery. So if any thrombus formations, so if any occlusion of these blood vessels, so it may use the decreasing the blood supply to this appendix, so may chance to get the gangrenous and also appendicitis. So is because of the thrombosis formations, any blockage of these blood vessels, any occlusion of these blood vessels, so it may give the decreased blood circulation to the appendix. So because of the decreased blood circulations, so it will give the necrosis and also gangrene. So it leads to the gangrenous appendicitis. So if anybody gangrenous appendicitis, so he's going to get that. So he's going to get the gangrene appearance will be in the appendicitis. So these are going to give the severe complications if they burst, or because of the fecal material may chance to get dislodged inside the appendix. So if it's broken or it's a burst inside in the abdomen, so it may going to give the severe complications and also sepsis. So coming to the appendicitis, acute appendicitis. Acute appendicitis is relatively rare in infants. So it becomes increasingly common in the childhood and also early adult life. So reaching a peak incidence in the teens and also early teens. So is this going to be acute appendicitis? The sudden onset of the inflammation of the appendix is the most commonly seen in the late teenagers and also early 20s are going to be may chance to get in the early 20s. And also after middle age, the risk of the developing appendicitis in the future is a quite small. So most probably is going to be happen in between the in the late teens and also early 20s, and also may chance to get in the middle age people, the risk developing acute appendicitis is in the future is a very quite small. So it may chance to get the chronic appendicitis, or that means is because of the is a progression of the infections or inflammations may give the appendicitis. but acute one is going to be happen in the early 20s. So what are the causative factors? What are the etiological factors? So there is no unifying is hypothesis regarding the etiology of the acute appendicitis. So until now, there is no exact causative factors for the appendicitis. So and also while appendicitis is associated with the bacterial proliferations within the appendix, as no single organism is responsible, and mixed growth of aerobics and anaerobic organisms is usual. So until now, there is no exact causative factor is unidentified in the acute appendicitis. So it may be because of the bacterial proliferations. So especially is going to be the aerobic and anaerobic organisms. So both are going to be the causative factors for the acute appendicitis. And also, if is there any another causative factor, any obstruction in the appendix. So if any obstructions such as any is a fecalith materials, so that is because of the any fecal materials or any calcium phosphate, and also bacteria and epithelial debris. So if anything occurs in the appendicitis, so may chance to get the obstructions, so it may give the acute appendicitis. And also next one is the obstruction of the orifice by the tumors. So is there any tumors in the appendix? That is the carcinoma of the cecum is the cause of the acute appendicitis in the middle age and also in the elderly. So these are the causative factors for the acute appendicitis. So these causative factors are especially is because of the any obstruction in the appendicitis. The obstruction may be any fecal matter. So that means any like a wastage material, fecal material, and also is going to be any calcium phosphate and also bacterial and also epithelial debris. Any waste material, if any obstruction in the appendicitis, it may give the obstruction in the appendicitis, it gives the acute appendicitis. Or in case of the any carcinoma in the cecum, may chance to get the acute appendicitis. If you see the pathological changes, so first thing is going to be happen, the obstruction is the lumen is essential for the development of the appendiceal gangrene and also perforations. So the major problem is going to be the obstruction. Is either obstruction due to like a carcinoma or because of the any debris and waste material, or is a fecal material. So these are the causative factors for the obstructions. So in the early appendicitis, the lumen is a patent despite the mucal inflammations and also lymphoid hyperplasia. So in the initial conditions is going to get the inflammations as well as the lymphoid tissue is going to get the hyperplasia. The thickness of the tissue is going to be increased. In children and also young adults, the infective agents probably is a viral initiates the inflammatory process, which within the narrow lumen and also appendix leads to the luminal obstructions. So the major causative factors in the children and also younger age group. So the inflammation is because of the any viral initiates, because of the any viral infections, and also because of this viral infection may lead to the lumen obstructions. Once the obstruction occurs, continues, the mucus secretions and also inflammatory exudation increases the intramural pressures and also obstructing the lymphatic drainage. So because of the obstructions or thickness of the tissues, so the pressure is going to be increased inside. So the intramural is going to be inside the lumen, the pressure is going to be increased. So because of this thickness and also it may give the obstructing the lymphatic drainage if there is no proper lymphatic flow also. So it leads to the edema, and mucosal ulceration develops with the bacterial translation to the submucosa. So may chance to get the swelling, edema, and also mucosal ulcerations may chance to get the ulcers in the mucosa. And also resolution could occur at the point and whether spontaneous or in the response to antibiotic theory. So if that means if the patient complain any symptoms and signs, so if he give any treatment plan like a medical management with non-steroidal anti-inflammatory drugs, or is the causative factor for the bacteria if we give the antibiotics with the intravenous fluids, so we can prevent the severe complications. So the appendicitis is going to be resolved with the antibiotic therapy. Progression of the condition leads to the further distension of the appendix, causes the venous obstruction, and also is the ischemia of the appendix wall. So if there is no progression with the antibiotics, as well as if any the intravenous fluids, if there is no improvement in the in the appendicitis, so it may leads to the congestion of the venous system, and also it leads to the ischemia. Because of the ischemia, may chance to get the gangrenous appendicitis. So with the ischemia, bacterial invasion occurs through the muscularis and also porphyria and also submucosa. So it because of this obstruction, so it may use the decreasing supply, it leads to the ischemia. So if you see this, finally the ischemic necrosis of the appendix will produce the gangrenous appendicitis. So these are the gangrenous appendicitis because of the any obstruction in the appendicular artery, so may give a chance to get the gangrenous appendicitis. And also it may lead to the this momentum and loop of the small intestine become the adherent and also inflammation to the appendicitis. So it may lead to the appendicular mass and also paracecal abscess formations. So after these, the inflammations, the gangrenous appendicitis, again is going to give the any mass development in the appendicular mass, or maybe the paracecal abscess may be developed. There's a pus formation in the at the paracecal regions. And also recent and rarely this appendiceal inflammation resolves. So it's leaving the distended mucosa. So sometimes it may rarely is resolved and also leaving a distended mucus filled organs. So it may chance to get that is going to be resolved. The inflammation is going to be resolved, but still there going to be is a appearance like is going to the mucosal of the appendix. So it's going to be that is like a finger-like projections. So like a folding or curving in the intestines. So it may also called as the intensitations. So it may chance to get the folding of these intestinal organs. So these are the pathological changes we can commonly seen in with associated with the appendix. So coming to here is going the great threat of the acute appendicitis is the potential for the peritonitis. So they may chance to get the inflammation of the peritoneum. So this peritoneum is also associated which promotes the process of extreme of the ages. So this peritoneum is going to be associated with, especially in case of the extreme of the age, or in case of the if anybody having the immunosuppressions, if they're having immune deficiency, diabetes mellitus, and also fecalith obstructions. So that means that any fecal material is obstructed in the appendix, so may chance to give the obstructions. And also a free-lying also pelvic appendix. So in case of the pelvic appendix, so may chance to get the peritonitis. And also any history of the previous abdominal surgeries, so which limits the ability of the greater momentum to wall the spread and also peritoneal contaminations. So previous history of any surgical procedures also may chance to get the peritonitis, that is inflammation of the peritoneum. In these situations, a rapid deteriorating clinical course. So if anybody get the peritoneum, so acute appendicitis along with the peritonitis, so they need the emergency procedure, that's the emergency treatments. Otherwise, they may chance to get the systemic sepsis syndrome. So it may damage that is in the intestine. So that means if the appendix burst or maybe is contaminated, so the contamination may spread into the intestines and also in the abdomen. So it may give the systemic sepsis syndrome. So coming to what are the clinical features of the appendicitis? So these clinical features are going to be especially the periumbilical colic. So that is going to, they are going to get the severe pain in the umbilical regions. So it moves from the surrounding to the umbilicus regions. The pain shift to the right iliac fossa. The pain is going to shift to the right iliac fossa. And also is anorexia, so unable to take the feeding. So and also nausea, so unable to take the food, so may chance to get the feeling of vomiting sensations. So and also in some patients they're going to lose the hepatite and also dull pain and also next to the navel and also abdomen. So it's going to surrounding to the umbilicus regions. So it may chance to get the going to the right abdominal regions. So right iliac regions will get shift to the pain here. And also they're going to get the nausea and vomiting sensations. Main thing is inability to pass the gas. So because of the abdomen is going to get the distensions and also because of the inflammation of the appendix and in the low grade fever may chance to get and dull sharp pain in the back and rectum region and also pain during the urination, severe cramp and diarrhea with the gas or constipations. So these are the symptoms of the appendicitis. So if you see the clinical like a classical features of this pain and also appendicitis, so just now we discussed is going to get the acute appendicitis. So it's begin with the poorly localized colic abdominal pains. So it's surrounding the navel region or in the umbilicus regions. So the pain is due to is a midgut visceral discomfort in response to the appendiceal inflammations. So because of the appendiceal inflammations, the midgut so is going to be the pain around the umbilicus is going to get the severe pain. So the pain is frequently first noticed in the periumbilical regions associated with anorexia, nausea, or two episodes of the vomiting. So they are going to get the severe pain around the umbilicus regions, and also it may shift to the right iliac fossa, right lower iliac fossa, and also 2 or 3 episodes of the vomiting sensations, nausea, and also vomit. They may chance to get the vomiting also. And so next commonly seen in the anorexia is the constant feature, especially in the children. So they're unable to take the food. So they don't want to take food because of the distension of the stomach. And also they feel the tightness and also the spasm in the abdominal regions. So may chance to get the like a severe pain in the abdominal. So because of these complications, they're unable to take the food. So it leads to the weight loss also may chance to get. So with progressive inflammations, the peritoneum in the right iliac fossa, so is going to be becomes the irritated. It's producing the intense, more localized, and also it gives the constant pain. So because of this constant somatic pain, so this will be the sudden cough or sudden movement. This pain is going to be increased. So it's going to get the irritation is going to be in the peritoneal regions, in the right iliac regions. So because of these irritations, so it will give the severe pain in the peritoneal regions. If they suddenly cough or if they do the movement, anything, the pain is going to be increased. So with these symptoms, we are going to identify with the physical examination, with the physical special signs, that is the SOA sign and also is the obturator sign. So we will discuss in the physical examination there. And also this typical sequence is present in the 50% of the cases. So the severe pain around the right iliac fossa and also this irritation is going to be is more commonly above the 50% of the cases. So in the elderly, so there is no localizations, and also this pelvic appendicitis gives the no somatic pain and also suprapubic discomfort and also tinnitus. So these features are we are going to find in the abdomen, especially in the elderly people and in case of the pelvic appendicitis. No fever during the first 6 hours. So they won't get any first 6 hours of the pain, but slight pyrexia. So is going to be happen after the 6 hours. So it may increase in the temperatures. So after the 6 hours, and also the pulse rate is going to be increased from the 80 to 90, like a pulse per minute. So is going to be, and also the two clinical syndromes of the acute appendicitis, that the acute is a catarrhal, and also acute obstructive appendicitis. So these are characterized by much more is a coarse onset of the symptoms, and also abrupt with a more tendency of the perforations. So these are going to be the acute conditions are going to give the severe symptoms. So then the other symptoms. So these are going to be the clinical symptoms are going to be just now discussed. Is a pyrexia, is increasing the temperatures, localized tenderness in the right iliac fossa, and as a muscle is going to get the guarding. So that means if we do any movements, they're going to restrict because of the pain. So they can get the movement, but the patient is going to restrict the movement. So that is called as the muscle guarding. And also rebound tenderness. Rebound tenderness means if you press, this one, if you press on the abdomen, so if you suddenly take out the pressures, so they are going to give the more pressure in the abdomen regions. So this is the common sign of the appendicitis. So these symptoms we can found during the physical examinations in the appendicitis. So these are some clinical investigations. The physical examinations, the signs are going to be, we are going to find the pointing signs and also Rowan signs, SOA sign and obturator sign. So these signs are how we are going to identify these are signs. So this one is the first one is the McBurnley point. So this McBurnley point, so what is the McBurnley point? So that is nothing but where exactly in between if you draw a line perpendicular to the like a ASIS anterior superior iliac spine to the umbilicus, so where the line is going to be intersect, so there the pain is going to be severe. So especially, so it's the right iliac regions, the pain will be there. So this point is called as the McBurnley point. If the patient complains, so because of the location of the appendix will be in the McBurnley point. So because of the pain is going to be radiate from the here to the umbilicus. So that is the reason umbilicus in the right iliac regions, but the pain is going to be distributed around the periumbilical region, surrounding the umbilical regions. So the pain is going to be aggravated during the coughing, or maybe if any excessive movement, so the pain is going to be increased. So if you palpate these McBurnley points, so if it going to be like a clockwise and also anti-clockwise, so the pain is going to be more, they're going to feel at this right iliac fossa. So it indicating this acute appendicitis. So this is called the McBurnley's point. So coming to this rebound tenderness. So this rebound tenderness is a clinical sign which there is a pain upon the removal of the pressure rather than the application of the pressure in the abdomen. So while palpating like in the abdomen is one special technique, palpation of the abdomen, physical examination of the abdomen. So if we remove the pressures, the patient is going to get the severe pain. While applying the pressure, so they won't get much like a pain, but if you remove the pressure and palpations, so the patient is going to get the pain. So that is called the rebound tenderness. So next one is going to be the rousing signs. So these rousing signs are going to be, so in case of while doing the deep palpations over the left iliac fossa, the pain will be in the right iliac fossa. So during the palpation, if you palpate from the left side of the iliac fossa, if you palpate from the left side to the right side, so if you give the pressure to the left side, so they are going to get the pressure inside the right side. So this is because of the continuous palpations. So it's going to because of the pressure, or this if you give the pressure in the left side, so because of the pushing of these internal organs, so the pressure is going to be increased in the right iliac fossa. So it may give the pain in the right iliac fossa. So this is this is called the rousing signs. So this is the clinical signs. These are the important clinical signs to investigate the appendicitis. So another investigation, other special test for the appendicitis is going to be the SOA sign. So SOA sign is going to be, we have to check this is a special test to identify the appendicitis. So the patient position should be in the sideline positions, and also if the position should be, for example, the patient in the sideline in the left side. So because of the right leg should be in the extension positions, in the hip extension positions. So why we have to bring it to the extension position means, so the psoas muscle is going to be the main action of the psoas muscle is the flexion of the hip. So if you bring them into the extension positions, so the psoas muscle is going to get the rest like a stretch. So because of the stretchings, so it may disturb so it may use the irritation in the right iliacal regions, in the iliac fossa. So it may use the positive symptoms. So that's the severe pain in the right iliac fossa. So it indicates the acute appendicitis or inflammation of the appendix. So the suggested inflamed appendix is located along the course of the right psoas muscles. So if you do the extension of the hip, so this muscle helps in the hip flexions. So if you do the opposite directions, this may give the severe pain. And also we can modify this test, this is psoas test, or otherwise if we give the resistance to the hip flexion. So if you ask the person to do the hip flexions in the sideline positions, so and also may chance to get the severe pain. So because of the irritation of the psoas muscles. So this also the positive test. Two types we are going to do the psoas test. We are going to bring the leg into the extension of the hip, as well as if we give the resistance to the hip flexions. So these tests are indicating is appendicitis. And also next sign is going to be the Dunphy sign. So Dunphy sign is nothing but if the patient is involved voluntarily, if they cough, so the pain is going to be in the abdominal walls. So it's going to be increasing. The pain is going to be aggravated. So this sign is indicating the appendicitis. So this also another sign. So if we ask the persons, so what sign? As well as if you ask the persons, if you voluntarily cough, if they cough, the pressure is going to be increased in the intra-abdominal pressures. So because of the increased abdominal pressures, it may irritate this appendix in the right iliac fossa structures. So it may give the severe pain. And also another sign is going to be the obturator sign. So this obturator sign also, so the patient should be in the supine-lying positions. So and also he can make them into the 90 degrees of the hip flexion and 90 degrees of the knee flexions. So if you do the internal rotation of the hip, so that means if you pull the leg away from the body, So is going to be the head of the femur is going to be rotated into the internal side. That's mean internal rotations. So because of the internal rotations, is going to give the irritation to the obturator muscles, and also is so who are having the pelvic positions. So it is going to get the irritation in the appendicitis. So it indicates the any pain indicates the is inflammation of the appendicitis. So these are the classical signs of the physical examination signs of the appendicitis. So obturator sign, SOVA sign, and also the Dulce sign and Dunphy sign, and next one is the Robinson sign. So these signs are very important to investigate to identify the appendicitis during the physical examination. And also another important of the appendicitis. So appendicitis may chance to get in the pregnancy also. Sometimes maybe we miss the because of any other other complications also. Sometimes may interpret with the pregnancy in the appendicitis. So this appendicitis is the most common is the extrauterine acute abdominal condition in the pregnancy. So it may chance in along with the pregnancy, and also this appendicitis also may chance to get some people. And also early non-specific symptoms are often attributed to the pregnancy, leading to the delayed diagnosis. So sometimes it may delay, so because of we miss any symptoms and also differential diagnosis. So the cecum and also appendix are pushed to the right upper abdominal quadrant, and also is a atypical site of the pain and tenderness. So while checking the palpations, so we are going to find in the pain in the upper abdominal quadrant regions, and also it's going to get the pain and tenderness. So the inflamed appendix may including the uterine irritations and also contractions. It may lead to the abortions also. So sometimes, so because of the inflammation of the appendix, so this because of the swelling, so it may give the uterine contractions, so uterine irritations. So it may give because of swelling, so the uterus is going to be irritations. So because of the space occupying lesions, so because of these space occupying or irritation to the uterus may chance to get the abortions. Fetal loss occurs in the 3 to 5% of the cases, and also increasing the 20% if the perforation is found at operation. So sometimes, so they may lose the fetal loss, and also because of the abortions, so because of the swelling of the appendix may chance to get the fetal loss also. So sometimes, so we may think about the other conditions also may mimic like appendicitis. So these are going to be, if you see in the children's, so these are going to be the gastroenteritis and mesenteric adenitis and Michel's diverticulitis, and also intersuspensions. So that is the curling and also folding of the intestines, and also Henschel-Sheldon's purpura and lobar pneumonia. See, these are the medical conditions also mimic like appendix symptoms. So if we differentially diagnosis, so with the special tests, just now we discussed about the SOVA sign and also operator sign and Gowassin sign. So these signs are going to be helpful to differentially diagnosis along with the investigation procedures such as and also X-ray, and also we are going to see the blood examinations, endoscopy. So all these are going to clarify we are going to final diagnosis, help to final diagnosis. So in case of like in adults also, it may use the mimics like symptoms like regional enteritis, so and also urotic colic and perforated ulcers, torsion testis, pancreatitis, and also rectus sheath hematoma. So these in the adults. So in the females is going to be the Michaelis gametes and salpingitis, that is the inflammation of the fallopian tubes, polynephritis, and also ectopic pregnancy, and also is a torsion and ruptured ovarian cyst, and also endometriosis. So these are going to be the symptoms are going to mimic like appendicitis. So we have to differentiate properly if they're having any other complication related to the female complications, or is there any inflammation of the appendicitis. So in case of the elderly, it is maybe the diverticulitis and intestinal obstruction, colonic carcinoma, mesenteric infarctions, or aortic aneurysms. So these are the differential diagnoses according to the age group with the appendicitis. So what are the investigation procedures? So if you see the investigation procedures, so we have to know the causative factors. Is there any infections or inflammations, or is infection because of the bacterial infections? So just now in the causative factor, we discussed about the causative organisms are the aerobic and also anaerobic organisms may chance to affect And also, so these are going to be identified with we are going to do with any urine analysis and also blood examinations. So with this test, we are going to identify what are the causative factors for the infections. And we have to check for the full blood count. So this full blood count is going to be gives the details of the how the blood count, how is the lymphocytes and also leukocytes, especially in infections. Why we have to check this blood count means, so in any infections, in the white blood cells percentage, that is going to be increased. The leukocyte count is going to be increased. So that is the reasons. So if we found any infections, so it may increasing the leukocyte count. So that is the reasons. So we have to do like a full blood count test. And also we have to found any infections such as the bacterial and also viral culture also we can check in the blood. We are going to found any bacterial infection or also viral infections. And also in case of the early urinary tract infections or any other related infections, also we are going to found in the urine analysis. So these are going to be give the clear information about the infections. So it will help to like rule out what is the causative factor for the appendicitis. And also, so in case of any infections such as the bacteria or virus, so if we send to the blood culture, so we are going to identify the causative factors. And also in case of the urinary tract infections, or maybe is related to the any bladder and bowel and bladder or intestinal, also we are going to identify in the urine analysis. Also we are going to find the causative factors. And coming to the special investigation procedures, so and also we have to do the pregnancy test. So sometimes, so just now we discussed in the differential diagnosis, and also may chance to get we can may chance to get the females in the pregnancy may chance to get the appendicitis. So in case of any ectopic pregnancy, so also may mimic like appendicitis. So we have to found any test, especially to rule out the pregnancies. So in the urine analysis or maybe in the blood test also going to reveal the like a pregnancy test. So nowadays many people we can do at home also with kits, so such as the HCG, like a hormonal test with in the urine. Also we are going to find the pregnancy positive or negative. And also next the examination is will be in the urea and also electrolytes. So these are going to be in case of any dehydration in the elderly patients. So because of the disturbance of the electrolyte imbalance, also may mimics like a symptoms like appendicitis. So in those conditions also we have to identify the any urea and abnormality in the like a urine analysis. If any urea excessive amount of the urea or any electrolyte imbalance, we have to found it with the urine analysis. And also in case of the plain abdominal X-ray, so in these X-rays are going to be helpful to identify any intestinal obstructions or any renal colic. So these X-rays are reveal any obstruction in the intestines or any in the renal, any like a obstructions you can reveal in the X-ray. And also in another X-ray examination is the ultrasound scanning. So this ultrasound scanning, so if any tumors or any obstructions or any inflammations, so if any gangrene, so all these things we are going to identify in the ultrasound scanning, we can identify. So these are the investigation procedures to identify, to rule out the inflammation of the appendix. And also the special test for especially in the pregnancy test. So because of this test is very important. So this can be mistaken for the appendicitis. So ectopic pregnancy. So ectopic pregnancy means the displacement of the fetus. So will be in the fallopian tubes. So if normally supposed to be in the dislodged in the uterus, but because of the any abnormality, so maybe the fetus development takes place in the fallopian tube. So this type of like a development, the fetus development in the ectopic pregnancy, it may mimics like the symptoms like appendicitis. So if we mistakenly, if we forget these things, so sometimes it may give the severe complications, and also it may give to the complications to the mother as well as to the baby also. So it won't be developed properly. So it happened when fertilized egg implant itself in the fallopian tube rather than the uterus. So this can be the medical emergency. So if any development of the fetus in the fallopian tube, so it will be removed immediately. Otherwise, it may chance to get the severe complication to the mother. And also, if the doctor suspect any ectopic pregnancy, so they may perform the pregnancy test. So to conduct this test, so they will collect the sample of the urine or blood. So they may also use the transvaginal ultrasound to learn where the, so that means where the fertilized egg has implanted. So either these things we can find in the ultrasound scanning, so especially the transvaginal ultrasound scanning. So ultrasound scans are going to do through the vagina, so they can find where exactly the fetus implant is there. Is it in the fallopian tube or in the is in the uterus? So with this transvaginal ultrasound, we can find exact the location of the fetus implants. So that is the pregnancy test to identify the appendicitis. And also next one is the management of the appendicitis. So this is depends upon the causative factors. So if it is the causative factor is the because of the bacterial infections, so bacterial infections we can solve with the antibiotic management. So if the condition of the patient is satisfactory, the standard treatment is the conservative treatment. So conservative treatment means, so it is going to be is antibiotic along with the antibiotics, and also analgesics, that is the painkillers, and also hospitalizations and intravenous fluids to minimize the dehydrations. So these are the main treatment plans if the patient is stabilized. So this method is called the Oceaner-Sheridan regimens. So these regimens are going to be used to, like if the is in case of the any, like the patient is stabilized and also it's not the serious complications. So with along with these regimens, have to strict watch on the vitals and also general state of the patients. So have to check for the vital signs, so which are the heartbeat and also heart rate and pulse rate and respiratory rate. So these things and also blood pressures have to move. That means we have to monitor. So if any alteration in these vital signs and also any other serious complications related to the any severe, like is unbearable pain in the stomach, or maybe is any the positive symptoms, so immediately how to shift the like a surgical ward and also how to do the emergency procedures such as the appendicectomy. So the inflammatory process is already localized. Surgery is difficult or maybe dangerous. So sometimes if they identify the inflammatory regions and locations, so sometimes it's not possible to do the surgical procedures. So in case of, so it may be in case of the impossible to find the appendix, or and also is a fecal fistula maybe in the farm. So sometimes if the abnormality in the appendix also, sometimes it's not possible to do the surgical procedures. So non-operative program is advised to be prepared to operate if the clinical deterioration occurs. So in this condition, if the raising pulse rate and also increasing and also spreading abdominal pain, increasing size of the mass, vomiting or increasing the gastric aspirates. So if any patients complain all these things, so immediately, so we are going to do the surgical procedures. So careful record of the vital R signs and regular abdominal examinations, extent of the mass. If it is helpful to mark the limit of the mass into the skin, a nasogastric tube with IV fluids and antibiotic therapy, and also clinical improvement is usually evident within the 24 to 48 hours in the 90% of the cases. So appendix should be removed after the interval of the 6 to 8 weeks. So if it is controllable, if the patient is stabilized, so we can give the medical management, so with antibiotics and also intravenous fluids and also analgesics. So if the patient is controlled and also have to monitor the vital signs, so then after the 6 to 8 weeks, so the surgical is going to be remove the appendix through the surgical procedures. So and also the treatment of the acute appendicitis is appendicectomy. If it is not controlled, so if it's not controlled with the conservative management and with the medical management, so the urgent operation is essential to prevent the increase in the morbidity and also mortality of the peritonitis. If the inflammation of the peritoneum, so immediately have to do the surgical procedures. So this one is there should be no unnecessary delay expect for the correction of the unstable general conditions. So that is the output of the urine and also is going to be the pyrexia and also post-operative perforation in the elderly patients. So that means we have to find any unstable conditions. So then only we are going to like a plan according to the symptoms of the patients. So then a single Pre-operative dose of the antibiotic usually sufficient to prevent the wound infections. So if any wound is there, if it's perforated or if the damage in the intestines, so if the in the appendicitis, so how to like with the antibiotics, so you have to reduce the wound infections. So if the peritonitis is suspect, therapeutic IV antibiotics for the gram-negative and also anaerobic bacteria should be given. So if the inflammation of the peritoneum, how to give the antibiotics intravenously. So it's related for the gram-negative and also anaerobic bacteria. So these should be the intravenously. So coming to the management for the surgical management, either conventional or is the open operation or laparoscopic techniques. So depends upon the patient requirement and also depends upon the surgeon decisions or the techniques are going to be that vary. So is going to be conventional operational open operations or is it going to be the laparoscopic. So is going to be the open one and also laparoscopic means through the small tube is going to do the with the surgical tools and also with a small like a tube like a video like a analysis. So with this one they're going to do the surgical procedures. So these all surgical procedure will do under the general anesthesia, and also this laparoscopic is going to be the nasogastric tube and also empty bladder have to do so before going to do the laparoscopic surgeries. And also next one is the palpation for the mass in the right inferior iliac fossa. So right iliac fossa. So we have to found any like a mass or also before this we have to do the palpations. We have to find the where is the position of the that is inflammations or also where is the swelling in the appendix. So these surgical procedures will be according to the surgeons and also depends upon the patient. It will be vary and the decision will be according to the surgeons. So these incisions will be different. So many incisions are there. So this is going to be the gridiron incisions, also called as McBurnley incisions, and also Lange incisions. And next one is we are going to do the lower midline incisions. So many different type of the incisions and treatment plans, surgical procedures are there. So first, if you see the gridiron or maybe McBurnley points, so this is going to be is in between the umbilicus and also anterior superior iliac spine. So where the tenderness will be more. So that point is called the McBurnley points. So an incision placed is perpendicular to the McBurnley points. So if you McBurnley perpendicular points, so is going to be the lateral 1/3 and also medial 2/3 of the imaginary line joining the anterior superior iliac spine. So this is the anterior superior iliac spine. So this is going to be the laterally 1/3 and medially 2/3 from the umbilicus to the ASISS. So where exactly the meeting point, so that will be the McBurn point. So this is the McBurn incision approach. So if you see in the abdomen, so many different type of incisions are and will do the surgical procedures. So according to the causative factor and also the position of the organs and depends upon the patient's complications and also the surgeon decisions. So it will be totally different. So here is going to be the Kocher's techniques and also gradient are also McBurnley points, Lange, and also is going to Rutherford and the median paramedians and so many like different techniques are there to remove the appendix. So these are going to be another one is going to be the Lange incisions. So these Lange incisions are going to be the skin creases incisions. So this is going to be the little slight, it is a variation of the McBurnley's point, but this incision that is made the same point, but is the transverse plane. So he's going to be the McBurnley point is going to be the vertical one. So he's going to be is going to be the horizontal. So this is going to be that is the difference between the McBurnley incision and also Lange incisions. So these are exactly 2 centimeters below the umbilicus, center to the mid clavicular and also mid inguinal lines. So from here, so if you see the mid clavicular and also mid inguinal regions, so this is exactly 2 centimeters below the umbilicus level. So it's going to be the umbilicus just below the 2 centimeter umbilical levels. It will be the mid is going to be the mid inguinals and also mid clavicular points. So that the incision is called as Lange incisions. So coming to the next one is the Rutherford incisions. So these Rutherford incisions are going to be, so here this is going to oblique muscle cutting incisions. So it's going to oblique muscles are going to be cut. So these are going to be extension of the McBurn incisions by division of the oblique fossa. So can be used for the right and left-sided colic resections and also cecostomy and sigmoidocolostomy. So in this Rutherford and Madison incisions, we are going to use for the not only for the appendicitis, also going to use for the the cecostomy and also sigmoidocolostomy. So this is going to be here we are going to resect that means the incision to the oblique muscles. So this is about the Rutherford and Madison incisions. Next one is the Kocher subcostal incisions. So these are going to be the extension of the incision is going to be from the below the xiphoid process. So it starts from the midline from the 2 to 5 centimeters below the xiphoid process and down extends downwards and also outwards and parallel to about 2.5 centimeters below the costal margin. So this is the costal margin. So this is the xiphoid process. So this is below the 2 to 5 centimeters. So xiphoid process and extending downwards, outwards. So this is the outwards and parallel to the, so this is going to be the costal margins. So this is the especially not only in the appendicitis. So this type of incisions also going to be is done in case of the cholecystectomy. So removal of the gallbladder also is going to do in the this postures and also incision methods. And coming to the paramedian incisions, so these paramedian incisions are going to be the place 2 to 5 centimeters lateral to the midline. So these are going to be the paramedian incisions. So it's going to be the 2 to 5 centimeters from the midlines, lateral midlines. So this is the lateral midlines. So this is the paramedian incisions. So these are going to be bulging transverse is the convexity of the rectus muscles. So it's going to be away from the median aspect of the lateral midlines. So this also the paramedian incision also used in case of the appendicitis removal. So and also another type of the surgical procedure is the laparoscopic surgical procedures. So which is called as laparoscopic appendicectomy. So these laparoscopic appendicectomy is nothing but is the minimally invasive surgeries. So these that nothing but going to send the like a laparoscope inside the like abdomen, so where the umbilicus is, where in the appendicitis is there. So there through the investing with this is the video guided like a tube. So here we are going to use the surgical tools are going to use to remove the appendix. So this is through the small like a hole, so through the laparoscope. And also the main advantage of this laparoscopy is going to be the minimal invasive. That means the scar formation is going to be less, and also this hospital stay also very less compared to the open surgical, like open appendicectomy than the laparoscopic surgical procedure. So these are the some treatment procedures and surgical management in the appendicectomy. So is open surgical procedures and also laparoscopic surgical procedures. And also after surgical procedures, so what are the complications may chance to get? Or maybe during the surgical procedures, so what are the complications may chance to get? So the problems encountered during the appendicectomy. So during the appendicectomy, so some problems are going to be arise. So that is going to be the normal appendix is going to be found. So sometimes after investigation procedures also may chance to get the normal appendix. So this demands careful exclusion of the other possible diagnoses, particularly the terminal ileosis and also Merkel diverticulitis and tubular ovarian causes in the woman. So these are may chance to mimic like symptoms like appendicitis. So after removing during surgical procedures, after removing the like a skin and also superficial fascia, after reaching to the appendicitis, so if you see there is no inflammation in the appendix. So it's because of the other causative factors may mimic like symptoms like appendicitis. It is usual to remove the appendix to avoid the future diagnostic problems. So in those conditions, surgeons are going to remove the appendix because of already open the structures, and also if there is no inflammation or if the swelling is there or not also, the surgeons are going to remove the appendix so to prevent the future complications. Even though appendix is a macroscopically normal, but approximately a quarter of the seemingly normal appendix shows the microscopic evidence of the inflammation. So sometimes it shows the microscopic is the evidence of the inflammations. But after entering into the appendix open, so sometimes it won't give the inflammations, and also we can make chance to found the normal appendix. So in those conditions also, surgeons are going to remove the appendix. And also sometimes the appendix cannot be found. So the cecum and also should be mobilized, and the tinea coli is a trace that their confluence before the diagnosis of the absence of appendix is made. So sometimes may chance to get because of the tinea coli also may chance to get the missing, or maybe is the appendix cannot be found. So this also one of the problem during the surgical procedures. And also an appendicular tumor is found. So may chance to get the tumor also we are going to found. So there is no inflammations. If it is more than 2 centimeters of the tumors, diameter can be removed by the appendicectomy. So in those conditions, there is no inflammations. So but because of the tumors, so it may use the swelling and also use the complications same like appendicitis. So and also larger tumors should be treated by the right hemicolectomy. So that means in case of the severe or be a larger size the tumors, it's a hemicolectomy. So half of the colon has to remove, otherwise it may spread to the other parts of the body. So in case of the malignancy. And also other complications are going to be an appendix abscess is found. So it may chance to get the abscess formation, the pus formations. So and also appendix cannot be removed easily in case of the abscess formations. So these type of appendix in case of the abscess formations, so should be treated with the local peritoneal toilets, and also is going to be drainage of any abscess with the IV antibiotics. So have to clear the debris and also waste material in the appendix, and also if the pus formations have to clean and also have to drain properly the abscess. After finishing the draining, how to give the intravenous antibiotics will help to prevent the infections. Next one is the appendicitis complicating is a Crohn's disease. So it's nothing but is the colon disease. So it's going to be the patient is operated for the appendicitis, found to have concomitant Crohn's disease in the ileocecal regions. And provided the cecal wall is healthy at the base of the appendix, and also appendix can be performed without increasing the risk of the enterocutaneous fistula, or in case of if anybody having this Crohn's disease, so may chance to get the enterocutaneous fistula. So in those conditions also surgeons are going to decide to remove the appendix. So rarely appendix is involved with the Crohn's disease. A conservative approach maybe is undertaken with the trial of intravenous steroid, systematic antibiotics to resolve the acute inflammatory process. So it's going to be rarely may chance to happen with this Crohn's disease with the appendicitis. So if we use the medications, especially the intravenous steroids and also systemic antibiotics are going to be helpful to resolve these inflammations. And next one is the appendix abscess. So the formation and pus formations. So may chance to get in the appendix. So these are going to be failure of the resolution of the appendix mass, or continuing the spiking like a fever indicates the pus in the index mass. So it's because of difficult to resolve with antibiotics and also IV fluids, and also if the steroids also sometimes we won't get any improvement in the appendix, the pain. So it may increasing the mass and also the continuing spikes, spiking fever. So if increasing the fever levels, so it indicating the pus formation in the appendix mass. So if any person having that is continuous increasing the temperature, so it may indicating the pus formation in the appendicitis. So ultrasound scanning and also abdominal CT scan identify the possibility of the percutaneous drainage. If not successful, is a laparotomy through the midline incisions. So if it is not controllable, so after the medications as well as the CT scan and also if the percutaneous drainage, so then we can go for the laparotomy. So through the midline incisions. So, okay, that's all about today's topic about the appendicitis. Hope you understand clearly. If you have any doubt, you can send me a message. I can clarify your doubts. See you in the next class with another topic. Thank you very much.